Desperate times call for desperate measures. This is especially true for many of us in healthcare, as we find ourselves adapting to new roles and new units, innovating to tackle a new disease while adjusting to a new surreal reality. Hence, in an effort to re-establish some degree of normalcy, we decided to resume the release of our episodes on the Neurocritical Care Society podcast. As I say, the show must go on, and at least now you can listen to something that is non-COVID related for the next 20 minutes. I hope you enjoy this episode.
Hello, everyone. Thanks for joining us for another Neurocritical Care Society podcast. My name is Chris Zametz. I'm a neurointensivist and emergency physician with TriHealth in Cincinnati, Ohio, where I'm the director of our neuro-ICU and stroke program. And we have the honor today of discussing a trial entitled Haloperidol and Ziprasidone for treatment of delirium and critical illness, which was published in the October 2019 New England Journal of Medicine. And we are particularly honored to have the first author of that trial join us today, Dr. Gerard. Dr. Gerard, you mind telling us a little bit more about yourself and the study team for this study?
Yes, my name is Timothy Gerard. As you said, I'm a pulmonary and critical care physician in Pittsburgh at the University of Pittsburgh and the UPMC Health System. And the trial was a multi-center, randomized, placebo-controlled, double-blind trial. It was conducted at sites throughout the United States. It was coordinated by a coordinating center at Vanderbilt University, where I trained and spent the first decade of my career before moving to Pittsburgh.
Great. Can you tell us a bit more about how you became interested in delirium and focused your research on this topic?
Yeah, absolutely. So it's hard to walk into an ICU without seeing a patient with delirium. It's a very common problem, especially if you're taking care of the most critically ill patients. I spend a lot of time taking care of mechanically ventilated ICU patients who are being treated for acute respiratory failure. And within that population of ICU patients, we see delirium anywhere from 50 to 70% of patients will develop delirium at some point during their time in the ICU with acute respiratory failure. If you look at a broader ICU population, the prevalence ranges from 20% to higher. And actually over time, we've seen the prevalence change in different ICU populations. And fortunately, with the mitigation of certain risk factors, including use of benzodiazepines and other heavy sedatives in the ICU, we've seen those numbers drop some over time. But even with efforts to reduce the prevalence of delirium and to reduce and address risk factors for delirium, it still occurs frequently. It's a very common problem. It's a challenging problem. It affects patients both in the short term in terms of increasing their risk of removing devices, removing endotracheal tubes, but also in the long term. We've seen a number of studies that have linked delirium during an acute critical illness with adverse long-term outcomes, including a long-term cognitive impairment in patients who had no clear evidence of pre-existing cognitive impairment before they became critically ill. So for all of these reasons, it's very, very interesting and important for clinicians, and I am an active clinician. And then also as a researcher, there are so many unanswered questions when it comes to delirium during critical illness. And one of the questions is, how do we treat these patients? Antipsychotics are very commonly used to treat delirium. A number of surveys that have been done over the past 2 decades have shown that haloperidol is the most commonly used drug to treat delirium during critical illness. And that number has been, or those results have been unchanged over the last 20 years. We've seen 80 to 90% of ICU physicians report in numerous surveys, including one that was published a couple of years ago that was a worldwide survey saying that they use haloperidol to treat delirium. And that's despite the fact that there was really no placebo-controlled data to show us that that drug works. In addition, in the last 20 years, we've seen an increasing use of atypical antipsychotics. Different drugs have been used, olanzapine, ziprasidone, risperidone, quetiapine. Different ICU physicians tend to have their go-to, but nevertheless, we see that atypical antipsychotics are becoming more and more frequently used at least up until a couple of years ago when the most recent data on their use was published. And because there are no placebo-controlled trials that support this practice, it was very easy to see that this is a question that needed to be answered and for which either answer mattered. And but by what I mean by that is that we knew that if we did a large, well-designed placebo-controlled trial testing the hypothesis that haloperidol as well as an atypical antipsychotic affects delirium or reduces delirium during critical illness, if we found evidence that it does, in fact, these drugs do in fact have that effect, that would lead to increased use. Whereas if we found compelling evidence that the drugs do not have that effect, that would also be an important, pertinent finding that would lead directly to changes in clinical practice, because there are clinicians that are using the drugs and there are clinicians that are not using the drugs. And that's really a great place to be when you're conducting a clinical trial, to know that your results will have an important impact on clinical practice regardless of what you find.
Great. That was fantastic. Thank you very much. Now, what I heard from there is that there were a lot of data on the clinical use of antipsychotics for the treatment of delirium and critical illness. Is there anything from a pathophysiologic sense on why there would be a potential benefit to use antipsychotics, or was a lot of this question spurred by the observations made with their deployment in the clinical setting?
Yeah, I would say that both are the case. I think the larger motivation was that the drugs were already being used. I mean, in my mind, that was the justification for doing a large multi-center trial rather than starting with the small trials. Now there have been smaller trials done, including one that we did as a pilot preceding the Mind USA trial. Our pilot trial had about 100, I think it had 103 patients in it, so it was smaller. And there's certainly a place for those kind of pilot trials. But in this case, because the drugs were already being frequently used, we felt that it was appropriate to go straight to, or at least next go to a large multi-center trial. Now, you asked about pathophysiology. There are a number of hypothesized mechanisms by which antipsychotics would work. Now, as soon as I say that, I'm remembering that antipsychotics, in some ways, at least when you're talking about mechanism of action, it's unfair or inaccurate to lump them all together, right? Because the different antipsychotic drugs each have different binding affinities for neuroreceptors, and so the drugs don't all work the same way. Now, some are more similar than others, and there are some that differ quite a bit from others, but there are no two that you would say, okay, these two drugs work exactly the same way. That said, there are hypotheses suggesting that dopamine blockade, and that's the main mechanism that we're thinking has a benefit when you're giving an haloperidol, that dopamine blockade would be helpful in the state of delirium. There were evidence from older studies, animal studies, and even studies in other patient populations, for example, those with psychosis, not necessarily delirium, but some of the similar symptoms, suggesting that dopamine blockade would have benefit. Similarly, atypical antipsychotics, they affect a lot of other neurotransmitters in addition to dopamine, such as serotonin and norepinephrine and other neurotransmitters. And so you could theoretically imagine a scenario where one atypical antipsychotic may have a different effect in the setting of delirium than others. So for that reason, you could argue, and we have heard this response after publishing our trial, well, you studied haloperidol and ziprasidone, but I use olanzapine or I use quetiapine, and these drugs are different. And I think from a standpoint of mechanism of action, the drugs are different. But the fact remains that none of the drugs that we're discussing have been proven in placebo-controlled trials to be effective as a treatment for delirium during critical illness.
Great. So probably won't keep our listeners on edge any further. Do you mind walking us through a little bit of the methods of the trial?
Sure, absolutely. And I guess I realized I just spilled the beans in terms of telling you the results. But since we published over a year ago, I'm expecting that most would know the results by this point. But it was a pretty traditional design in terms of being a placebo-controlled, double-blinded, randomized trial. It was a multi-center, as I said. It was done in 16 sites across the United States. There were 3 treatment groups. One was placebo, another was Ziprasidone, and then the third was Haloperidol. The drug was given twice daily, and we selected that frequency based on the pharmacokinetics of both Haloperidol and Ziprasidone. Certainly, the Haloperidol, when given in clinical practice, is sometimes given more often, but we chose the frequency and the doses of the drugs based on what we know about pharmacokinetics of these drugs, as well as the receptor binding affinities and the concentrations that are achieved with the doses that we gave. We delivered the drug for up to a maximum of 14 days, and that was really a pragmatic decision. Over 95% of patients who were delirious in the setting of critical illness end up having resolution of their symptoms or otherwise declining and dying, unfortunately, within that time frame. So our interest was primarily in treating for up to 14 days because that's where most of the patients end up having their delirium. Alternatively, if the patient improved, we stopped the treatment. So the drug was titrated both in terms of the dose, up or down to a maximum or to a minimum, and then also stopped depending on the symptoms. So we assessed patients every day during the treatment period with the CAM-ICU, or the Confusion Assessment Method for the ICU, to identify delirium, and that's a well-validated tool for the use in this patient population. And then if a patient had a resolution of delirium, so they were no longer delirious according to the CAM-ICU, initially we would reduce the dose, and then if they remained delirious for more than 48 hours, we would stop the drug. And the study drug could be restarted if delirium recurred, as long as it was within that 14-day period, and also I should point out, as long as they were still within the ICU. So the drug was only given in the ICU setting. There are a number of concerns about these drugs, both the atypicals, including Ziprasidone and Haloperidol, having effect on the QT interval, and because of that, we wanted to ensure that we were giving the drugs in a setting where the patients were being continuously monitored with telemetry, as well as with frequent nursing assessments to evaluate for any sort of side effects. So for that reason, if the patient either had resolution of delirium or left the ICU or reached that 14-day treatment period limit, we would stop the drug. And alternatively, we would continue the drug if they continue to have symptoms within the 14 days, and we assessed them not only for delirium, but also very carefully for side effects. So we assessed or measured the QTc before every dose, and we also evaluated the patients for side effects using validated tools such as the Modified Symptoms and Angus Scale and some other tools as well.
So summarizing it, these are medical or surgical ICU population with respiratory failure or some type of shock who were at risk for delirium, who initially were screened. And then they were, if consented, they were then randomized to one of these 3 treatments.
Yes. Thank you very much for drawing our attention back to the study population itself. I didn't make that point very clearly, but you did. We wanted to study high-risk patients, not just any ICU patients, but those that are highest risk for delirium. And for that reason, we enrolled patients who were either mechanically ventilated with acute respiratory failure or had shock. Now, it turned out that the very large percentage had respiratory failure rather than shock, but there was a significant minority who had shock. And one thing that was interesting about this clinical trial in terms of its design is that we attempted to, when possible, actually obtain informed consent from authorized representatives even prior to the time that the patient was delirious. And that allowed us then to, once the patient became delirious, immediately randomize them and start treatment, rather than at that point having to go and identify a surrogate and trying to obtain informed consent.
Great. And actually, one of the interesting things I found in the paper were the number of patients who declined to participate. That's just for other investigators out there. Did you have any comments on that? So it was about 3/4 of the population who were potentially eligible declined to participate. Any lessons from that?
Yes, and just to clarify, those decisions were made by authorized representatives, which was almost always a patient's family member, rather than the patients themselves, since they were typically either delirious or sedated and in a comatose state. Although it's less and less common, fortunately, for patients to be comatose from sedation in the ICU, it still does occur in this patient population. So 75% of those who were eligible and approached had family members who said, no, we don't agree to our loved one being in this trial. That seems like a high number, and it certainly is a higher number than I would like as an investigator, but it actually fits with what we have expected based on other trials in this patient population. Specifically in the critically ill patient population, family members, as you would expect, and as I think almost any of us would be, they're really frightened at this period of time. Their loved one has just been admitted to the ICU in the last day or two, and they're at risk for dying, and they've been hearing from the clinical team that their loved one is really sick and they're hoping they'll survive. And then here comes a researcher saying, well, would you be willing to agree to participation in this trial? And even though what we were studying were drugs that they may end up getting even if they're not in the trial, and that was an aspect of the trial that we could say, in all honesty, to the surrogates, look, we're trying to understand, based on this research trial, whether these drugs truly have a benefit in this setting when patients get confused or delirious in the ICU. And we're not studying an experimental drug that is never used. Now, they are experimental in the sense that they are not FDA approved for this indication, and we're very clear about that. But they are drugs that are being used by doctors frequently. And, they're concerned, they're worried, and they often don't want to make a decision with the thought in the back of their mind that, well, maybe this will end up harming my loved one rather than helping them. And we want to be honest with them. We don't know if the drug helps or hurts or has no effect at all. And it's common in that setting for authorized surrogates or family members to say, you know what, I don't think that we want to agree to that right now.
Gotcha. Thank you for that background. So your primary endpoint, again, was to look for the number of days alive without delirium or coma, and other secondary outcomes were the duration of delirium, the time to freedom from mechanical ventilation, ICU discharge, and then also looking at ICU readmission and hospital discharge. Wondering if you mind telling us a bit more about the characteristics of the population that was included, and then the findings as it relates to your primary and secondary outcome.
Sure. And before we talk about the characteristics, I want to briefly comment on the primary outcome, because it is one that could be perceived as being quite complex. Given that it's a composite endpoint of 3 different outcomes, those 3 being delirium itself, which is obviously of the most interest in this trial, but also of coma and of death. And the reason that we chose this composite endpoint is because both coma and death are common in this patient population, and they both have they both are likely to confound any measurements of delirium. Obviously, if a patient dies, they can no longer be delirious, so that's the reason that death can confound the duration of delirium. But additionally, if a patient's comatose, whether that's from heavy sedation or from the effects of their underlying illness, in that setting, you can't assess or detect delirium. And so both coma and death can therefore confound any tests that you're doing to determine the effect of a drug on delirium. And what we didn't want was a scenario where a drug that, for example, was harmful and led to more death appeared to actually reduce delirium, but it wasn't through a beneficial mechanism. Instead, it was through a harmful mechanism. That this composite endpoint allows us to avoid that kind of confounding by death or coma. And the problem with the composite endpoint, however, is that it's affected by all three. So you don't necessarily know if you see a difference in that endpoint just looking at that data if the change was because of an effect on delirium or because of the effect on coma or death. And that's why we used we looked at the duration of delirium as a secondary endpoint. It was very important to look at both of those sort of in concert to understand the effects of the drug. So we ended up enrolling 566, randomizing 566 patients to placebo, haloperidol, and ziprasidone. And as you would expect in an ICU patient population who's being treated for acute respiratory failure or shock, about half of the patients were older. The median age was a little younger than 65. It was about 61 in the three groups. And a little under half of the patients were female. And the majority were white. About 80% were white. About 15% black. And then 5% or less were other races. All of these characteristics were similar in the three groups. The most common diagnosis at admission to the ICU for the patients in this trial was ARDS or sepsis. And when you add those two together, it was about half of the patient population that had ARDS or sepsis. And that was what we expected based on our entry criteria being mechanical ventilation or shock. One characteristic at the time of enrollment that's received a lot of attention was the percentage of patients that had hypoactive versus hyperactive delirium. So I should comment briefly on that. About 90% of patients had hypoactive delirium, whereas only 10% or maybe 9% had hyperactive delirium. The reason that hypoactive delirium was so common in this trial at the time of enrollment is because we tried to enroll as quickly as we could after the patients were admitted to the ICU with the criteria that we were screening for and then developed a delirium. And as I've already said several times earlier in the podcast, sedation remains common when treating mechanically ventilated ICU patients, especially during the first couple days that patients are mechanically ventilated. And because sedation early on is still common, delirium tends to be hypoactive at that time. But that doesn't mean that hyperactivity didn't occur more frequently than 10% of the time in this patient population. And that's something that we didn't spell out very clearly in the paper. It turns out that almost 40% of patients had hyperactive delirium at some point. So most of the patients in this trial, or almost half of them, had what I would call mixed subtype delirium, meaning that they fluctuate between hypoactivity and hyperactivity. And alternatively, the other half were hypoactive throughout their period of delirium.
Right. Thank you for enlightening. That's actually really important. And I think I agree that when I think a lot of people read the paper quickly, that wasn't immediately apparent. Wonderful. So with that said, any difference in any of the primary or secondary outcomes?
Yes.
With the
so it's really easy to sum up the results. Across the board, every single outcome that we examined, whether that was an efficacy outcome like our primary outcome of delirium coma-free days, the secondary efficacy outcomes like duration of delirium or time in the ICU or hospital, or even in our safety endpoints like the number of patients that had to have the drug stopped because of extrapyramidal symptoms, for example. All of these endpoints were similar between the three groups. Now, we want to be very careful about, we're not necessarily claiming equivalence in terms of every endpoint, because there are certain endpoints, like, for example, the safety endpoints, these all occur infrequently enough that to prove that there was no difference, you'd really have to have a massive trial, much larger than the 566 patients that we enrolled in this trial. But for the number of patients that we included and for the outcomes that we assessed, we found no evidence of a difference in any of the efficacy or safety outcomes.
Great. With regards to the way the placebo group actually ended up treating, so you're enlightening us to higher prevalence of hyperactive delirium episodes due to the high prevalence of mixed type delirium within this population. Did you all collect any data or make any observations about other pharmacologic interventions that were occurring outside of antipsychotics in the placebo group to mitigate the hyperactive behaviors that may have compromised or threatened some of their safety devices or otherwise in the ICU?
Yes, we did collect, well, we collected very detailed data on any sort of psychoactive drug, whether that be a sedative or a analgesic, like fentanyl is very frequently used in this patient population. We collected detailed information about the doses and frequency of all of the sedatives that are commonly used in these patients, as well as analgesics and even other atypical or typical antipsychotics. Now, we worked very hard to try to prevent open-label antipsychotics, that is, an antipsychotic that was not part of the study protocol, from being given. But we weren't able to prevent that in 100% of cases. In fact, we saw that over 10% of the time in all three groups, there were atypical antipsychotics or open-label haloperidol given. So that tells us two things. One is that these patients were continuing to have symptoms that their clinicians, that the ICU team thought should be treated. Even though we were given explicit instructions, this patient is in a clinical trial, they're already have a 2/3 probability of receiving an antipsychotic, and giving additional antipsychotics outside of the trial may increase harm. Even with those warnings, about 10 to 15% received open-label antipsychotics. What's additionally interesting about that is that was not more common in the placebo group than it was in either of the active treatment groups. So being on the standing dose of haloperidol or of ziprasidone while delirious actually ended up having no discernible effect on giving the likelihood of receiving an open-label antipsychotic, and it also did not affect the other sedatives. So I frequently am asked, well, does your trial really prove that these drugs aren't beneficial for hyperactive delirium or for agitation? I'm convinced that because you use the ChemICU, you've shown that there's really no evidence that it improves delirium, the full syndrome of delirium, but I think it could very well reduce agitation. And my response to that is, well, we measured all of the other drugs that are given for agitation, and overall, they were the same in the three groups. So I would expect that if the placebo group was having more agitation than the haloperidol group or the ziprasidone group, that would then, in turn, generate a higher use of sedatives and analgesics. And it didn't. We saw that the doses between the three groups of those classes of medications all appeared to be the same. And unlike the safety outcomes that may occur infrequently, and it might be difficult to tell without a larger trial if there's a statistical difference, the sedatives are very, very commonly given. And so it would be easy to detect in a trial this size if there was a substantial difference in the amount of sedation given, but we saw no evidence of that.
That was fantastically enlightening. Thank you for sharing that. I think that's a really important point. Any other conclusions from your data or take-home points for the listeners?
Yes, I guess the one take-home point I would make that actually doesn't come directly from our trial, but I think it's important to keep in mind when interpreting the results of our trial and then deciding, whether or not it's going to influence your own practice, is that we've seen now in half a dozen large cohort studies that the frequency with which patients are prescribed antipsychotics at the time of discharge after having had it started for delirium in the ICU is, in my opinion, alarmingly high. Almost every one of the studies that have looked at this, so I'm talking about observational data, in observational data sets, when you ask the question, among patients who received an atypical antipsychotic, or any antipsychotic rather, for delirium and were not on one of these drugs prior to their critical illness, what percentage end up leaving the hospital with a prescription for that drug? It's 20%. So 1 out of 5 patients and this has been consistent in multiple observational studies, 1 out of 5 patients who are started on an antipsychotic for delirium end up leaving the hospital on it at a time when we know they are not going home in a delirious state. So that, I think, is really concerning, and it's important to keep in mind. Should we be starting a drug that doesn't have evidence of efficacy based on large placebo-controlled trials like Mind USA, when there's a risk not only of the drug having no benefit to the patient in the hospital, but of them ending up on it as an outpatient? That's a setting where the drugs actually have a black box warning from the FDA.
Right.
So as intensivists, it's easy to think about, well, what am I doing right here in the ICU? But it's important also to think about what effects may the decisions that I make now have later on for this patient.
Fantastic. Did you capture any data on the frequency of even more minor safety issues like urinary retention or some of the other anticholinergic side effects you can sometimes see with this population? I share that because as a clinician, particularly taking care of elderly folks.
Yeah, that is a really great question, and we actually did not collect any data specifically on urinary retention. Most of these patients did have Foley catheters in, at least for the period of time that they were in the ICU. I think there are some ICUs that try to get those out early, but it's still pretty common for them to have it at least throughout the period of time that they're in the ICU, delirious, on the ventilator. So we didn't capture that. We did measure akathisia. There aren't great tools for measuring that in this population. So we used a visual analog scale, and that obviously has some problems because if the patient's delirious, they might not actually be able to reliably tell you if they're having akathisia. That said, this was our best option for measuring akathisia. We asked patients who could respond to rate their sense of akathisia, and we described that to them using a scale from 1 to 10, and didn't find any evidence of a difference between the 3 groups. But I think there are other important effects, as you mentioned, anticholinergic effects and others that may be affecting patients that we didn't directly measure.
Great. Thank you. And the last question, where do we go next with delirium? I mean, what other things should we be exploring? What other things should we be thinking about, both from a clinical trialist standpoint as well as a clinician, to try to mitigate the effects of delirium in our critically ill patients?
That's a really great question, and it's definitely one that I and others in the field continue to wrestle with. I mean, certainly one area of focus is in the implementation science field, and that is continuing to work on translating evidence into practice regarding delirium risk factors. For example, benzodiazepine, sedation, it's less common now than it used to be in the ICU, but it's very clearly a risk factor for delirium in this patient population, and it is still a risk factor that many patients are exposed to. So that's one area where we can mitigate risk, is choose different sedatives. And when we do sedate, try to sedate as lightly as possible or as lightly as necessary. There are other risk factors like immobility. There's studies, including randomized trials, that suggest that patients who are mobilized earlier during critical illness have less delirium, or that their duration of delirium is curtailed when they're mobilized. So that would be another area. And then in addition, in the research side, I think we clearly need to do more work examining mechanisms. Now, it's easy, I think, to get nihilistic about mechanisms of delirium because, many believe that, and I think it's reasonable to think this, there is no single overarching mechanism. There are actually lots of different mechanisms that lead to similar symptoms, and that may be true, but I don't think that should dissuade us from studying the mechanisms and trying to understand the pathogenesis of delirium, which may lead to better treatments in the future.
Great. Thank you again for your time. This has been a wealth of information. I know I learned a ton, so really appreciate your time that you've taken to talk to us about this trial and delirium and critical illness, Dr. Gerard.
Sure, you're welcome. Well, thank you for inviting me.
With continuously updated content on topics ranging from acute ischemic stroke to clinical evaluation of coma and brain death, prognostic assessment, and traumatic spinal cord injury, Neurocritical Care OnCall is the only product of its kind to offer content exclusively dedicated to the practice of neurocritical care. This interactive, subscription-based website features tables and figures, videos, author insights, and sections specific to nursing, pharmacists, and APPs. To learn more about subscribing to Neurocritical Care OnCall, visit www.neurocriticalcare.org/OnCall. Use promo code PODCAST for an extra 10% off your subscription.
The NCS podcast series is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and advocacy in neurocritical care. Our production staff includes Fawaz Al-Mufti, Ramani Baloo, Mike Brogan, Josh Levine, Benjamin Miller, Sterain Shepard, Jim Siegler, Sarah Stern-Nezer, and Chris Zamet. Our senior producer is Bonnie Rousseau. Our administrative staff includes Bonnie Rousseau and Angel Gindel. Music is created by Mohan Kadapali from the Division of Neurocritical Care at the University of Miami. The NCS podcast series is available on NCS On Demand and wherever you may listen to your podcast. For more information, please follow us on Twitter @Neurocritical or on Facebook. I'm Fawaz Al-Mufti, and thanks for listening.